Good morning, everyone. My name is Iqbal Ratnani. I am the intensivist at CVICU at Houston Methodist Hospital. As we all know that imparting and sharing knowledge is the cornerstone of Houston Methodist Hospital philosophy. And keeping that philosophy in mind, Houston Methodist Hospital last year established Center for Critical Care so they can impart the best of medical education not nationally but globally across the globe. Not only share the knowledge but also learn from people across the globe. And keeping that objective, charter, aim, we have decided that the one way to do is to arrange grand round on the monthly basis on the topic where there is a need to talk about more, where the evidences are not much available and there is a need for education. And keeping that in mind, this is our first grand round under the banner of DeBakey Heart and Vascular Center on the topic of refractory vasoplegia in the post-cardiac patients. And we will continue this tradition, we will continue this practice every month. In fact, actually we have planned another very good grand round on a very good topic, and that would be critical care issues in pregnancy, which will held on April 30th. And our speaker is a renowned speaker nationally, Dr. Stephen Levine. She is the professor of medicine at UT, University of Texas, San Antonio. And she is the program director of pulmonary critical care medicine. She will be imparting grand round on April 30th next month. We will continue that tradition every month. Not only that, we will have a huge symposium, beautiful symposium, which we are doing since last 2 years with hands-on workshop in critical care, knowledge, lectures on April 9th and 10th. And please go to our website and register yourself. Today we are talking about refractory vasoplegia, and I have a panel of three very distinguished speakers. First of all, I have Dr. Faisal Masud, who is well known in Houston community. Actually, nationally, he is well known. In the COVID, his hard work was so well known. He was at the New York Times, and his work is unmatchable. He is mentor to so many students, so many doctors. He is one of my own mentor. He is professor of medicine, and he's professor of clinical anesthesiology. He is the medical director of Center for Critical Care. He will be our first speaker. In the panel, on my right side is another very, very good speaker who has done fabulous job and very, very popular among residents for his teaching, for her teaching. And Dr. Atiya Dhala, she is the associate professor of clinical medicine and clinical surgery, and she is our intensivist at surgical and liver ICU. Before we go into start our presentation, there are some housekeeping announcement. You can go to paulev.com and enter DeBakey and respond to activity and ask your questions. Second, you can join us by text, and you can text DeBakey, DEBAKEY, to 37607 and text in your message also. So you can ask question, and one of the objective of today's presentation is not only to impart knowledge, rather we would like to ignite the discussion, because this is one of the topic where there is not much literature there. That's why we want to learn from the other side of this forum, that what you can teach us, what we can learn from, and we would like to see some good discussion. So I will invite Dr. Faisal Masud to start his presentation. We will have three parts on this presentation. Dr. Faisal Masud will go introduce about the refractory vasoplegia, what it is, and how to define it, and then there will be some comorbidities which can bring vasoplegia on the bedside, and last but not the least, rather most important part, will be dealt by Dr. Atiya Dhala. She will be talking about the treatment, where I'm sure most people have the interest that how to deal with this dreaded situation on the bedside. So I will hand over to Dr. Faisal Masud.
Thank you, Dr. Ratnani. Good morning and welcome to the Critical Care Grand Round under the DeBakey CV Education. As you mentioned that this is the topic of vasoplegic shock, and I chose this name as chameleon shock. The reason I chose is that there is so many definitions, so many different interpretations of vasoplegia, vasoplegic shock, that I think it's important for us to recognize that and to address that. So my disclosure is in front of you. So we're going to talk briefly about nomenclature, definition, and some insight into pathophysiology of how all of this develops. So it's a chameleon shock. Why? Because there are many names of it. It has been called distributed shock, vasoplegic syndrome, vasoplegic shock, and it's really different from vasodilatation, which is not an uncommon phenomenon taking place in our patients. But the fact that there's so many definitions, names, it becomes very challenging. So distributed shock, again, I want to kind of highlight how all of these different pathophysiological gave to this vasoplegic, which some people call distributed shock. So for example, neurogenic shock, pressor support with requiring norepinephrine, anaphylactic shock, support with these are therapies. But if you look at it, the neurogenic shock, the anaphylactic shock, endocrine shock, drug-induced, septic shock, and post-cardiac, these are all different labels, but the pathophysiology underlying is the same. It is that they are so much vasodilated and they become less responsive. So as you can see, I gave you three initially: vasoplegic syndrome, vasoplegia, distributed shock, and even all of these endocrine shock come into play. So how this plays out? There is no universal consensus on clinical definition. As you can see, I already showed you 7 different labels. The absence of consensus clinically based definition of vasoplegia impedes progress in understanding the pathophysiology. Vasoplegia actually, it is a syndrome of pathological low systemic vascular resistance, the dominant clinical feature which is reduced blood pressure in the presence of a normal or raised cardiac output. Vasopressor refractory shock occurs when vasopressor therapy does not result in adequate arterial blood pressure despite sufficient extra fluid volume expansion. That means you've given the patient, you've made the patient euvolemic, you've started the vasopressor, and the patient is still not responsive and has a low blood pressure. In fact, the heart is working reasonably well, but there are other problems. So as you can see, these are complex. So I wanted to show you that how underestimated this vasoplegic shock is. Hypovolemic shock, the incidence is about 16%. It can be losses. Cardiogenic shock, about 16% incidence. Obstructive shock, as you can see from P or tamponade or anything, 2%. Look at vasodilatory or distributed shock, 66%. And why is that? If you look at the slide 2 before me, which I mentioned, that so many things are feeding into surgical, neurological, endocrine, septic. So the fact that we have a lot of vasodilatory distributed shock we're dealing with, and that's so important for us to understand the pathophysiology, to understand which, especially in cardiac patient, why it is much more incidence issues and what the management is. So blood pressure regulation is basics. I remember reading our physiology from Guyton, and there's a lot of basics which is very important. These 3 physiologic systems, the renin, angiotensin, aldosterone system, the sympathetic system, and arginine vasopressor system, they all work in synergistic manner to control your blood pressure environment. And that's very important because, as you'll see in the slides later on, and especially with Dr. Dhala, she will touch why it is. Normal thing, physiological, heart pumps, you have resistance vessels with the smooth muscles, and you have normal tension, normal blood pressure. Pathological state is that your heart is still pumping, but the smooth muscle tone or the vessel is compromised or lost, and then you have hypertension. And when you go into the vasodilatory shock situation, even when you apply exogenous therapies like medications, vasopressin, norepinephrine, it doesn't respond as appropriately. So this is very important for understand the basics. Now this is a little bit a busy slide, but I want to kind of highlight how some of these things play out, whether it is the impact is coming from extramural and intramural, whether damage associated, molecular damage, or a pathological associated, whether it's transfusion, organ transplantation, sepsis, trauma. There is a whole different mediators which are playing a role. So let's go to the next slide, which is much more. And I have to give credit to Dr. Dhala. She is the mastermind. She does this a fantastic job. So let's talk about this thing. You've got inflammatory modules, IL-1, IL-6, tumor factor. Then they start impacting direct increases the sympathetic nerve with norepinephrine, adrenal medulla, epinephrine, critical, hypothalamic axis, vasopressin, all of these things which I mentioned. When they get used up, they get depleted. Then you have a decreased norepinephrine impact on the receptors, decreased vasopressin, decreased angiotensin, and all of these factors start to play a role in the basic pathological state in which the calcium channel, the potassium channel, and the the vascular smooth muscles start getting impacted. So let's talk about the other ways with these factors impacting the INS. The INO impacts ATP sensitive, potassium channel, the C and GMP increase. Both these two different mechanisms, as you can see, impact your calcium channels, your potassium channel. They impact this myosin dephosphorylation that leads to the muscle don't respond. When the smooth muscles in the vessels and arterial vessels don't respond, they stay dilated. They don't squeeze. When they don't squeeze, no matter how much fluid you pour in, the blood pressure is still compromised. And when that goes to a non-responsive state, that's when you get a vasodilatory shock. Now, this is, I want to highlight the next slide is it's important to separate vasodilatory shock or distributed shock, which is listed in this, compared to other shock. See how the preload is decreasing hypovolemic, it's decreasing distributic because the vessels are very dilated. Your tank, which was 3 liters, now it's about 7 liters because they're vasodilated, they have more capacity versus obstructive cardiogenic. Afterload is decreased in distributive or vasoplegic, whereas increase in hypovolemic and cardiogenic both are increased. Cardiac output is decreased in all except for distributed, and then these are the example of that. Now there is one thing that in life things are not always black and white. There is a lot of overlap, and that's why I want to talk about a mixed shock state, especially in patients who have had cardiac surgery and or devices, that you can have a cardiogenic shock along with a vasoplegic shock. That means you can have an LVAD or an RVAD. You can have a right ventricle failure, and on top of that, you can have a vasoplegic shock. In cardiac surgical patient, there are other factors related to it. You can have basically impact of the cardiopulmonary circuit. You can impact of the warming of the patient. You can have impact of medications like milrinone or promine. So we have to really be mindful of that what vasoplegic shock state is. It is how different factors, intramural and extramural, play a role. It becomes less responsive to medication. You can have a mixed stage, and you still have to deal with the cardiogenic component along with the vasoplegic shock component. So a lot of times that's very dicey, and that we have to be mindful of that. So I thought a little briefly mention about some of the definition of vasoplegic state, some of the pathophysiology, and then I'll give it to Dr. Ratnani.
So we are going to change gear a little bit, and from the patho, we will go more towards the clinical side from the basics. And the idea behind talking more about clinical, because most of the people, when they go to the bedside, they actually want to know that what's going on. And look at this side. Whenever you have a patient, and I'm talking about the comorbidities, these are your typical patients who have diabetes, smoking, hypertension, heart failure. And to know that which patients are coming and looking at the history, I want you to pay attention to dialysis part. And if you look at the odd ratio, this is a beautiful study which was done almost 3 years ago, and that came from Yale New Haven. You see that the odd ratio for the people who are on dialysis, the odd ratio for developing vasoplegia is 2.9. And the reason I'm talking about this, to understand that there may be something we may be able to do preoperatively, perioperatively, postoperatively to treat vasoplegia, and why this is important. And the reason I highlighted dialysis, that one theme when Dr. Dhala will talk and later I will talk, one theme will consistently come, that kidney plays an important part in this vasoplegia. So here, if you see heart failure and dialysis, I want you to keep that in the back of your mind. Diabetes also has some increased risk when people are coming with diabetes, diabetes. So please keep in that mind. If you keep that in back of your mind, we will go forward. And now here, look at the disparity and this is the comorbidity on the basis of the surgical procedure. Previously, on the previous slide, we see those clinical conditions, that's how patient present, but this is when patient is going for the surgical procedure. You see that mitral valve replacement is well known to cause vasoplegia, but in the tertiary centers and in the community centers now, only the LVAD placement and heart transplant is becoming mainstream. Look at the odd ratio for ventricular assist device. When patients go for LVAD placement, ventricular assist device, the chances of developing vasoplegia is 12.5, which is way more beyond than when people are coming from mitral valve replacement or people are going for heart transplant. That is also high 4. But you have to be very vigilant as a clinician, as a bedside, when you hear that patient is coming to your unit after LVAD placement. So these are the comorbidities I am talking here, and we will see that how we can make difference in life of our patients. This is a beautiful slide, and this is an interesting story that they have about, they were looking into, and they found 10 articles, but the number of the patients were 30,000 in this study. And this is really something, it comes out in January 2019. They looked into 30,000 patients and made this beautiful graph where they found that actually the CPB time, the cardiopulmonary bypass time, is the number one factor. They have this, if you look at this, this is the highest, and then axillary clamp time. Here also you see renal failure again. And so this thing will continue to pop up, the renal failure, the kidney will consistently be there. But one thing which I want to pay you to attention is look at this amount of RBC transfusion. That also increase the risk of vasoplegia. This is extremely important. Please don't give blood if patient don't need blood. When you give blood to treat yourself, then it would be a problem. Give blood only when patient need a blood, because when you give blood, you increase the chances of vasoplegia. When patient is coming for the isolated cap, that's one of the time when you have a little relief, but other times you have to be always vigilant. Now going to the other slide. And this is one of the slides where we talked about the clinical conditions, we talked about the surgical conditions we are coming. I here want to highlight few of the medicines which have shown that vasoplegia could be a problem when people are on heparin, when people are on AC inhibitor, which is very well known. But in the lower part, I have put two medicines which I want you to pay attention. One is the beta blocker, and second is the calcium channel blocker. And why I put those into the blue and I put the question mark, the reason is that going to the next study, let's see if I can. Yeah, let's see.
The big one.
Yeah. Here it is. So this is an interesting slide, and this is a very important slide. This is a study of 2,000 patients which came out from Yale in 2015, and they look into 2,000 patients from 2009 to 2011. There are three important lessons in this slide. One is that they found that 66% of the patient have some kind of vasoplegia. So any patient coming to your unit, you have to be number one thinking on hemodynamics as a vasoplegia. The other thing is that they found that beta blocker, if given preoperatively or perioperatively, beta blocker can have some protective effect on vasoplegia. And they try to do another important thing. They try to develop a score, which also they were looking into the stratification of the score. So now experts are looking at how we can work on vasoplegia, and that's the one of the point I want to make here, that vasoplegia is not only just a dreaded condition and you deal with it, but you may be able to modify it by questionably giving beta blocker. The evidences are very weak. There are scores coming up where you can stratify the vasoplegia. So this is a very important work done from the Yale in 2015. Yeah. In our institution, we are doing heart transplant. So I want to talk a little bit about that. One thing, when your patient is coming after heart transplant, few things which will make difference is that how long that patient was on LVAD before going to the LVAD. And the second, again, you see that the kidney is popping up here. If patient creatinine is high, then your chances of vasoplegia is high. And your bypass time. If your bypass time is high, with every hour increase, the longer the bypass time, your chances of vasoplegia will keep going up.
We can turn the slide.
Okay.
You can say next.
And here, the most important point I want to take, that why this vasoplegia is important and why this vasoplegia, we should deal with this vasoplegia in the early stages. If you look at this slide, this is very interesting. They actually followed this patient for 8 years. And you see that the difference, here on the slide here. You see that first year, second year, third year, fourth year, and look here, by the 5th year, the mortality suddenly start dropping. So and this is the vasoplegia at the time of the surgery, which make difference for the years and years to come. So if you start, this is a very important slide to pay attention, that if you treat vasoplegia in the early part, you have the benefit for 5 to 8 years. The difference in mortality is amazing. So this is why this is an important topic, that vasoplegia need to be dealt. We need to understand this topic. We need to see that how this disease need to be dealt with to have the effect for years and years. Next slide. We'll go to the next slide. Again, I was trying to show that for years and years you will have a difference there. And then we'll go to the next slide. And this is an interesting slide. And this slide will pop up in this kind of a slide will pop out. I'm trying to make it more simplified. And here, a few things to pay attention. You see kidney is coming again. Renin is coming from the kidney. AC, your angiotensin converting enzyme is coming from the kidney, and your angiotensin converting enzyme is coming from the lung. That's why when people are on angiotensin converting enzyme, they start having this symptoms of cough. But if this renin is not doing the work from the kidney, your angiotensin is not going to go into angiotensin 1, will not cleave into angiotensin 2, and you will not have aldosterone secretion, you will not have vasopressin secretion, and you will not have effect on receptor 1, angiotensin 1 receptor, you will not have effect on angiotensin 2 receptor, and you will have vasodilatation. So this renin and angiotensin converting enzyme coming from kidney actually plays the role. One side part is that this angiotensin converting enzyme actually block the bradykinin, and this is the vasodilatation happen. That's why when you have angioedema from the angiotensin converting enzyme inhibitor, you give FFP, which has bradykinase, which get rid of bradykinin and trying to get rid of this vasodilatation. But again, kidneys coming here with renin. Now, why I'm emphasizing on renin? Because as a physician, we are tuned to know the biomarkers. If it's an MI, we want to know troponin. If it's a sepsis, we want to know about lactic. So if it's a vasoplegia, is there any troponin or lactic acid for the vasoplegia? And we are now finding that actually renin could be the lactic acid or troponin of the vasoplegia. And if renin goes up, then you maybe say that vasoplegia is getting better, vasoplegia is work. So again, paying attention to the renin would be very important. Next slide. So renin level, here it is, another study which was done, that's also came from Yale, and they look into the renin and the survival in the patient, and they found that the higher the renin level, the vasoplegia would be higher. So this renin level is really one of the things which is we can pay attention, we can actually measure, and we can do that. Going to the next slide. And this is the study which was done, and you see that there is a threefold increase in the renin level. There is a threefold increase in the renin level in the people who are in vasoplegia. So can we measure the renin and know that vasoplegia is going on? This is one of the possibility which is coming in the future. And renin concentration correlates positively with angiotensin 1 and 2, as we saw in the previous slide. So this is extremely important to know that we might now be getting a lab marker where we can see that the renin is the can be measured. Now going to the next slide. This is again, renin concentration correlates positively with angiotensin 1 and 2. So, and some of the centers can actually measure angiotensin 1 and 2 ratio. They can do renin level, they can do the angiotensin 1 and 2 level. So this can be done. So we are in very near future, we will be able to actually measure the vasoplegia, and this is a big improvement. And as we have seen in the previous slide, that if we treat vasoplegia, shorten the time of vasoplegia, if we treat vasoplegia, we can have the benefit for years and years to come. Going to the next slide. You see again here, the ratio is going up, and the p-value was really so good that we know that renin level really correlates with the vasoplegia. Going to the next slide. And so what are the take-home messages? Take-home messages is that when you have a patient, if you are on the bedside, can we predict vasoplegia? Can we predict vasoplegia after cardiosurgery? So any patient, as I said, that keep in mind that the kidney plays an important part. So if your patient is coming who has a surgical procedure, which is a combined surgical procedure, and if patient is having a long time in the OR, and if patient has kidney issues, CKD, hemodynamic instability during the OR, these all you can predict the vasoplegia. So this is a very important message, that you can predict vasoplegia. So going to the next slide and summarizing everything, it can be anticipated. If you know the predictor values, clinical conditions, that where it's coming from, it can be anticipated. And we may be able to do some prevention preoperatively. Maybe we need to later on through studies need to see that is calcium channel blocker. We stop AC inhibitor now regularly 48 hours before the surgery to prevent the vasoplegia. Beta blocker, it can be measured through renin. We can do the hemodynamics. It may be, and it is treatable, and I will hand over to Dr. Atiya Dhala, which is going to talk her fabulous part of treating this.
Thank you very much, Dr. Ratnani. I'm going to continue and talk about vasoplegic shock management. I'm going to discuss about I think the slides.
I think we're sorting out the technical issues, which are very common whether you're doing it in person or in virtual. Technical challenges.
Not working here.
While Dr. Dhala sorts out, Dr. Ratnani, I think you bring up a very interesting point about diagnosis, which we really haven't had in the past before, that we have a potential of diagnosing vasoplegia.
This was very interesting that very near future, and renin is a test I check with the lab that could be arranged, and they can have a good turnaround time also. So if we are anticipating that there is vasoplegia going on, we can send the lab, talk to the lab, and if it's a vasoplegia, as we said, that this effect lasts for years and years, not months, not weeks, years and years. So if we have a good parameter, we can actually follow like a simple lactic acid. This is a future.
I think so, because we've seen patients who are on 1, 2, 3 pressor for not 1 hour, 2 hours, but sometimes for 24 hours or 36 hours, and then we don't know which direction they're going to take place. So I think this is important development, which will be how quickly it is available, what is the turnaround time for renin. The other thing is, I think the impact of beta blockers is key, and that's why the STS talks about beta blocker being given before the cardiac surgery as such a big, quality measure. And you're telling me that may have a potential even in vasoplegia. Not only from negative outcomes overall.
But Dr. Masud, one more thing which was very striking for me, and when I was a junior resident, we were trained reflexly to give blood, but one thing is that sometimes we treat ourselves giving blood. Patient may not need blood. We can get away with the blood, and giving blood itself could be a risk factor for vasoplegia, even 1 unit. So if we don't need it, those simple interventions, simple thinking can serve our patient for many, many years.
And I think I think Dr. Dhala's technical challenges have been surmounted. Thank you.
Sorry about that. And the focus of my talk is going to be on vasopressors and non-vasopressor salvage therapies for the management of mean arterial pressure and organ perfusion in patients with vasoplegic shock. As you may already well know, that a lot of the drugs that we use in vasoplegic shock and the data that we use to treat patients is extrapolated from data on septic shock patients. I'm going to focus on these 4 drugs: vasopressin, angiotensin II, methylene blue, and hydroxycobalamin. The sympathetic nervous system is impaired and in a shock state, and the first go-to drug for every type of shock is norepinephrine. And it is also the standard treatment and the first-line treatment for vasoplegic shock. But as you know, if you go into high doses of catecholamines, they are going to have some adverse effects. And furthermore, when a patient has severe vasoplegic shock, the vascular smooth muscle cells become unresponsive to norepinephrine. So what do? We need a second-line drug, vasopressin. It's an essential stress hormone that is released when there is hypotension. and a shock state. It is released by the posterior pituitary and binds to the V1 receptors, causing vascular smooth muscle contraction and vasoconstriction, and thus increases the blood pressure. It also causes vasoconstriction of the renal efferent arterioles and platelet aggregation. It also binds to the V2 receptors, causing water reabsorption, the antidiuretic hormone properties, and release of coagulation factors. Now, in a shock state, there's a depleted vasopressin levels, and therefore when you give back vasopressin, it causes an impressive vasoconstrictive effect and a catecholamine sparing effect. The VANCS trial. This was the first prospective randomized double-blind single-center trial from Brazil with 300 patients with vasoplegic shock after cardiac surgery. The intervention, and this was the initial drug that was used, was vasopressin, and the dose was 0.01 to 0.06 units per minute. The comparator was norepinephrine at a dosage of 10 to 60 micrograms per minute to maintain mean arterial pressure. Now, the primary endpoint was a composite of mortality and severe complications, and they occurred far less in the vasopressin group, about 32% of the patients, compared to 49% of the patients receiving norepinephrine. This is a Kaplan-Meier curve showing event-free survival, and as you can see, the vasopressin patients had more event-free survival compared to the norepinephrine group. If you look at the 30-day mortality, it was flat across the board. But if you look at the primary outcome of acute kidney injury and the secondary outcome of atrial fibrillation, there were far less patients in the vasopressin group than in the norepinephrine group, and this was statistically significant. Therefore, the authors concluded that vasopressin can be used as a first-line vasopressor agent in post-cardiac surgery vasoplegic shock, and this improves clinical outcomes. Let's move on to angiotensin II. Now, the renin-angiotensin-aldosterone system is dysregulated in vasoplegic shock. Now, angiotensin II is a naturally occurring hormone. But here we're going to talk about intravenous synthetic human angiotensin II, which was FDA approved in December of 2017 for the treatment of septic and distributive shock patients. As I mentioned earlier, in septic and distributive shock, there is depleted angiotensin II levels, and therefore when you restore angiotensin II, it improves hemodynamics through enhanced vascular tone. You start off usually with 20 nanograms per kilogram per minute, and it's titrated every 5 minutes up to a maximum dose of 80 nanograms per kilogram per minute. And you can do this in the first 3 hours, after which the dosage is reduced to a maintenance dose of 40 nanograms per kilogram per minute. The good news about this is as you titrate up or down, the hemodynamic effects that you see at the bedside is instantaneously, within seconds. Now, angiotensin II is not a new drug. It's been around since the 1950s and 60s, and it was in the ATHOS trial that this drug resurfaced because they were able to prove that it was a very potent vasoconstrictor and it had catechol sparing effects. So in this pivotal phase 3 trial by Khanna et al., the ATHOS 3 trial, published in 2017, a double-blind, placebo-controlled, multi-center randomized controlled trial in adult patients with vasodilatory shock. An important point to remember, like Dr. Masud had mentioned, these patients are already on high-dose vasopressors. So these patients were on greater than 0.2 micrograms per kilogram per minute of norepinephrine, or an equivalent of another vasopressor. The intervention here was Ang2, and it was initiated at 20 nanograms per kilogram per minute, and the comparator was placebo. The primary outcome was mean arterial pressure of greater than or equal to 75 millimeters of mercury, and this increase happened by R3, without an increase in the dose of the background vasopressors. In this slide, you can see that the patients in the angiotensin II group had a robust improvement in their mean arterial pressure in the first 3 hours compared to placebo. And here it shows that patients in the angiotensin II group, their background vasopressor dosages were able to be reduced much faster than the patients in the placebo group. So the primary efficacy endpoint of mean arterial pressure response at R3 was achieved in 70% of the patients in angiotensin II group and 23% in the placebo group. As I had mentioned before, these patients, when they received the study drug, they already were on a background of vasopressors. And one of the major adverse events in angiotensin II group patients was thromboembolic events and deep vein thrombosis. Now, a post hoc analysis of this ATHOS-3 trial, a subset of patients, 16 patients with vasoplegia after cardiac surgery with cardiopulmonary bypass, was looked at in greater detail. And they found that the patients in the angiotensin II group had a significant decrease also in the background dose of vasopressors. Mean arterial pressure target was met. The 28-day mortality was the same. And there was no venous or arterial thrombotic events in this group. Now, patients on cardiopulmonary bypass, what happens is the duration of the bypass corresponds with the amount of inducible nitric oxide synthetase. And this results in increased nitric oxide, which then increases the vascular levels of cyclic GMP, leading to vasoplegia and vasodilatation. And that brings me to talk about methylene blue. So methylene blue is commonly used in vasoplegia. How does it work? It inhibits endothelial nitric oxide synthase and soluble guanyl cyclase, in addition to direct binding of nitric oxide. And by doing this, it causes blood pressure augmentation. The dosages, as mentioned here, 1.5 to 2 milligrams per kilogram over 20 to 30 minutes. And in most of the times, it is followed by an infusion. Now, there are two subsets of patients you really want to be careful and maybe want to avoid this drug, is in patients that are at risk for serotonin syndrome. And that is because methylene blue is a monoamine oxidase inhibitor properties. And patients that are on SSRIs or monoamine oxidase inhibitors, methylene blue should be avoided. It also should be avoided in patients with G6PD deficiency, as it may lead to hemolysis. So if methylene blue is given in a rescue setting, what should we expect? So Lay and colleagues gave a single dose of methylene blue in the background of norepinephrine to patients with vasoplegia after cardiopulmonary bypass. And they saw a nice improvement in the systemic vascular resistance and mean arterial pressure, and they were able to create a catechol sparing effect with down titration of norepinephrine. So we know that methylene blue works, but how does this translate into improved clinical outcomes? So Levin and colleagues studied just that, and they realized that the duration of vasoplegic syndrome was much shorter in the patients that received methylene blue, 2 to 3 hours, compared to control group, where some of the patients were in vasoplegic shock even up to 48 hours. The other thing that it did was it showed that the mortality of this patient population was much less, and the adverse events were much less in this population. So when do we actually give methylene blue to these vasoplegic patients? So this was a retrospective study. So they included about 118 patients that were vasoplegic, but within 72 hours of cardiopulmonary bypass. And one of the outcome measures that they looked at was major adverse events. And they realized that in the methylene blue group, there was major adverse events all across the board. So what they did was they stratified the patients, whether they got methylene blue early, like in the operating room, or late, if they got it in the ICU. And then they realized that the early group had much less incidence of renal failure and also had a decreased 30-day mortality. So early administration of methylene blue improves survival and reduces the risk-adjusted rate of major adverse events in these patients. Moving on to hydroxycobalamin, this was FDA approved for cyanide toxicity. And when they treated patients with cyanide toxicity, one of the side effects was extreme hypertension. And that's because it is a potent and direct inhibitor of nitric oxide and nitric oxide synthase and directly modulates hydrogen sulfide, leading to hypertension. There were no reports of hemolysis in the G6PD population and no associated serotonin syndrome. And therefore, it's a good alternative for patients with vasoplegia and G6PD deficiency or risk of serotonin syndrome. But the downsides is it's quite expensive, more expensive than methylene blue, and interferes with the dialysis machine and falsely elevates and alters some of the lab values. So what are the studies of hydroxycobalamin? Well, there are no randomized trials. Most of the data are extrapolated from case series and case reports. There's a lot of heterogeneity in the way the drug is administered, and there's a lot of heterogeneity in the effect of the drug. Now, this is the first study by Fay and colleagues that compared methylene blue monotherapy with combination therapy. And the authors suggest that there might be a slight advantage to the combination therapies in the fact that the absolute vasopressor dosages were more reduced in the combination therapy group. So, let's create an algorithm of which drugs we're going to pull out of this toolbox now. So you have a vasoplegic patient, as defined by Dr. Masud, with a high cardiac, normal or high cardiac index, a low mean arterial pressure, a low systemic vascular resistance. They're already on greater than 10 micrograms per minute of norepinephrine, and you're steadily increasing the dose of vasopressin. Start thinking, what do we pull out next? And I guess the likely choice would be angiotensin II, and you'll start that at about 20 nanograms per kilogram per minute. And then you'll look and see the mean arterial pressure response. Is it adequate? If the answer is yes, then you would titrate down other vasopressors while maintaining angiotensin II and follow your institution guidelines on how to titrate angiotensin II. Well, if your mean arterial pressure response is not achieved, then you would increase Ang2 to a max dose of about 80 nanograms per kilogram per minute in the first 3 hours. And if you still do not see a mean arterial pressure response, then you would likely titrate down Ang2, increase your other vasopressors. Of course, look for other things. Does the patient need volume? Correct the hypocalcemia, correct the metabolic acidosis, and use your corticosteroids. And then consider adding methylene blue and or hydroxycobalamin. And we all know that one size does not fit all. And so the recommendation is the multimodal therapy. So you want to bring out your catechols first, and then you go to your arginine vasopressin pathway, and then bring out angiotensin II. And then you have your other salvage therapies that you can add on to help your patient with vasoplegic shock. And thank you very much for your attention, and we'll open up the forum now to questions. Thank you.
So I see here some comments, and those are very important comments here. Dr. Dhala, you already have fans all over, and excellent presentation by Dr. Dhala. I got one of the comment. I know that she is an excellent teacher. I always learn from her, always. But two important messages and or comments I'm seeing here. One is that blood transfusion need to be limited not only for the vasoplegia but overall immune response, and it exacerbates the post-op inflammation. I can't say anymore. This is a very, very right comment, very precise comment, very good comment, and I always believe that when we give extra blood product for no reason to patients, we actually harm them. And
I think I'd like to pose a question. one thing we talked about was, identifying and then, risk factors and management. I think one of the key things we'd like to pose to it is really when you talk about identifying, how do you identify? Are we going to put swans in everybody? Are we going to do non-invasive mode? Are you going to do echo? Because if you just go with the blood pressure cuff monitoring, then you may not necessarily know what's happening. So could you shed some light on that? Because if you don't know what you're treating, then your therapy probably will potential harming. So could you shed some monitoring?
I think that's such an important point, Dr. Masud. And I think now we have so many wonderful things like echo at the bedside, critical care echo. I think that's an excellent tool, because if you put it on the heart and you see that this patient has a normal or a high cardiac output, a good contraction of the left ventricle and right ventricle, and you have a low mean arterial pressure and systemic vascular resistance, I think you have your diagnosis. And also, as you resuscitate and every step of the way, if you're not seeing a good mean arterial pressure response to your drugs, you want to go back and repeat that echo. Look at the IVC. Have we given this patient enough fluids? Look at other things that could help solve these problems. Look at the, if this patient needs CRRT maybe, because the patient has refractory acidosis, then these vasopressors aren't going to work. So I think goal-directed fluid management and pressor management, I think, is the key to the success here.
Yeah, I think so. So I think we do have, you're absolutely right, goal-directed, knowing what you're treating with echoes, and there are monitors that we have available which can calculate your SVR and your cardiac output non-invasively. I think the thing should be non-invasively. And you brought up a very interesting point. We cannot underestimate the power of addressing the metabolic acidosis issue, because if you don't do that, no matter what chemicals we add to the patient will be non-responsive. So identification, especially with the non-invasive approaches, will be beneficial. And in cardiac surgical patients in the OR, they probably have one advantage, that they probably have much more a chance of having a PA catheter. They have other modalities which they can allow to identify. Okay.
So let me ask you one question, Dr. Dhala. There is a lot of recent controversy, and some people are very pro-vitamin C, some people are very anti-vitamin C. Let me ask you, if nothing is working, do you see any downside of giving vitamin C? Because people always question that. Sometimes we see study in favor, sometimes recent studies are coming against vitamin C. What's your thought on that?
So, the four major trials on vitamin C, the Citrus ALI, the ACTS, the vitamins, and the Victus, the most recent one was Victus, all of them were negative. I mean, their outcome measures were all different. I mean, some looked at SOFA scores, some looked at, but there was no mortality benefit. And so I don't usually put it in my armamentarium of treating shock. I use the other two in the salvage therapies. I do use thiamine and corticosteroids, but I stay away from vitamin C. It's a cheap drug. All of these drugs are, so compared to angiotensin II, compared to vasopressin, I guess it's a cheap drug. But for me, the studies didn't make me feel good about using this particular drug. So I don't add it on.
So steroids, as you bring a very interesting point, because in the septic shock, recommendation guideline, if the patient is requiring increasing dose of vasopressor, then they do recommend to potentially think of steroids. Do you think in vasoplegic shock coming not from septic but from cardiogenic, is there a role for steroids?
I think so, because you never know. I mean, there are drugs that we use in the OR that could have an anaphylaxis, anaphylactoid component. Steroids, I think, don't throw in the towel, they say, before using the steroids. So I would definitely use the steroids. I don't think there's any downside to it. And if it will definitely help you get rid of your shock faster. But that's what the steroid study shows. It didn't show a mortality benefit, but it did show that you get rid of your vasopressors a lot sooner. Okay. So yes, I would.
Dr. Dhala, we have a question from the audience. What are your thoughts on interleukin inhibitors for inhibition IL-6 and IL-1?
I haven't seen those studies in vasoplegic shock patients. They've used many other drugs, but not IL-6 inhibitors. So I probably have to research that. I didn't find that as I was reviewing the literature.
So I think COVID showed us one thing. There are a lot of drugs out there who have been used in different modalities and may have impact, and perhaps there is a role for some of these drugs to decrease some of these mediators and an impact, just like we saw in COVID.
Yeah.
You know, we never thought the rheumatology drugs will become a rheumatologist, but we're doing it.
So there's a question, Dr. Masud, for you. Are you concerned about high dose steroid in a sternotomy patient?
So, yes. So if you're using high dose steroids for a prolonged duration, then you do impede wound healing. Then you are causing catabolic stage, and that can be negative. I think for a vasoplegic shock stage, if you use it for about 24 to 48 hours, that has not been shown to really impede healing in sternotomy patient. However, if you have an open-ended utilization of steroids for 7 days or 10 days without de-escalating, yes, then you can do that, because not only the wound healing, but it drives your glucose high up, and that is a known factor. So if you have to use it, I would say use it for no more than 24 to 48 hours.
Okay. So we are reaching our time to finish our talk. We are finishing our hour. Again, I'm making this announcement that under the banner of Center of Critical Care, we are having grand rounds on the every month basis. And our next grand round would be on a very, very exciting topic, the critical care challenges in pregnancy. That would be by Dr. Stephen Levine. She is the professor of medicine at UT San Antonio, and she is the program director of critical care and pulmonary medicine there. She will be here on April 30th at 8 a.m. That has been lined up. And before that, we have a very, very popular, very, very exciting event on April 9th and 10th, which would be hands-on, and we will be inviting few, it would be limited in person and then virtual, but it is always so popular that we always look forward that annual event on April 9th and 10th, our critical care symposium, again under the Center for Critical Care. We really want to see you there, and we want to share, we want to learn from each other. Thank you very much.
Thank you.
Thank you.